Welcome to Leadership Chats with Dr. Wise, the Not a Lecture podcast where we explore what it really means to lead in today's complex healthcare environment. I'm Dr. Wise, and in this series, we're having real conversations about essential leadership concepts. We'll talk about what you need to know, what you want to know, and what you'll actually use in practice. And yes, what you need to know to pass the exam. Each episode, I'll be joined by a guest expert who brings real-world experience and insight into nursing leadership, from managing care teams to fostering a culture of safety and everything in between. Whether you're listening on the go or settling in with your notes, this is your chance to deepen your understanding and connect what you're learning to real-world practice. No slides, no lectures, just meaningful conversations that bring leadership to life. Welcome back to Leadership Chats with Dr. Wise. Today, we're going to dive into one of our most practical and sometimes even intimidating topics, which is going to be delegation and supervision. So if you've ever wondered, can I delegate this to a UAP, or what am I responsible for and what is somebody else responsible for? You're not alone. It can be a topic that can be kind of confusing, but I think we can break it down and make it pretty manageable. So delegation is not just about knowing the rules, but it's also about using your clinical judgment, something you've been developing all along the way, making sure we communicate clearly and leading with confidence. So you can lead with confidence and use those skills even as a student or a new grad. So to help us break this down, I'm joined today by Jaime Zahirniak. She is an experienced charge nurse who brings real-world insight into effective delegation and what that looks like on a busy hospital unit. She's going to help us connect the dots between the theory, the clinicals, what safe, accountable delegation really looks like. So let's get into today's chat. So welcome, Jaime. I'm glad to have you here and be a part of this conversation. Why don't you start us off by telling us a little bit about yourself and your background, your experience, whatever you'd like to share?
Sure. So I went to Texas Tech through the accelerated BSN program back in 2019. Prior to that, I had a degree in business administration. I kind of worked in the healthcare field, but more on the administrative side than anything else, and decided I wanted to go back to school for nursing. So graduated in 2019. Ended up working on the same unit that I spent all of my clinical hours on. It was a transplant unit, and then decided that I wanted something a little bit more challenging. So I moved on to the ICU, both of them at Methodist Dallas, south of downtown. Been working there for 5 years now, looking at what year it is now. I've been working there for 5 years. And in the ICU for the last 2 years, and started charging there towards the end of last year.
Awesome. So you have some good experience to build on and that special piece that you graduated from this program. So, and I got to know you throughout that program because you're one of my students and a stellar one at that. So you've done a great job in your career, and it's been great to see you grow since your graduation. So you're accomplishing great things. So why don't we start off by clarifying some of the basics around assigning, delegating, and supervising. So to kind of lay the foundation here, I'm going to give us some definitions of those three different categories when we think about this topic. So assigning is going to be the process of transferring responsibility. And I think those two words are really important. We're transferring the responsibility to somebody else. The accountability, the authority for client care is given to another member on our healthcare team. When we look at delegating, we are transferring the responsibility of a task, but we're retaining accountability in the outcome of that task. So the transfer of responsibility is there, but I think we need to add to that with delegation that we are retaining accountability for the outcome of that task. Supervising is going to involve directing, monitoring, and evaluating the care that's being provided by somebody else, and making sure that it meets whatever standard we have, but generally safe quality care. So with those definitions in mind, Jaime, how do you see each of these showing up in your daily role as a charge nurse?
Sure. So the big one out of the three that you listed that as a charge nurse is assigning, right? So every morning when I come in earlier than the day shift does. And I talk to the night charge nurse. We look at our assignment board. We go over each patient, gives a brief rundown of what's going on with that patient, what needs to happen with that patient. And so we'll take a look at that together. What's going on with each of these patients, how acute they are, what special skills they might need throughout the day. And then we have to match the nurse to that specific skill that they'll need. Like if a patient needs CRRT, we've got to
Mm-hmm.
make sure to assign that patient to a nurse that is got that competency and capable of doing that. Uh, Similarly, if a patient is really, really acutely ill on multiple pressors, we're likely not going to give that to somebody that's just out of residency,
Mm-hmm.
because that might be too much for them.
Right.
So assigning is the big one. Um, as a charge nurse, the delegation is a little bit different, because I can't really delegate my role to somebody else because I still have to
Mm-hmm.
retain the um, accountability for whatever happens. And so my role is a little bit different as a charge nurse, but delegating to a PCT, maybe setting up a room. So if a code goes off in the somewhere else in the hospital, um, I can delegate to a PCT to go and set up an empty room so that when we bring this patient over to the
Mm-hmm.
ICU, the room is set up, right? And
Right.
that still allows me to check back in with them and make sure that they've done the thing that I've asked them to do.
Mm-hmm.
Supervising is another big one as a charge nurse. So multiple times throughout the day, I'll round on the unit and make sure that nurses have everything that they need in order to make sure that they're able to provide the care that they need to their patients.
Mm-hmm.
Um, I may step in if they tell me that there's something going wrong with their day with a patient, a visitor, or a provider. I can step in and help out in that way.
Mm-hmm.
So accountability or assigning and supervising are really the two big ones in my role as a charge nurse.
Awesome. Yeah, those are great examples, and they match up perfectly with what we just heard in the definition. So let's shift gears a little bit and talk about this from a staff nurse perspective. So, when you're not in the charge nurse role, you're a nurse working on the unit, taking care of your own group of patients. How do you see assigning, delegating, and supervising show up in that role on a day to day basis?
Yeah, so assigning is a little bit more difficult as a floor nurse, because I never really, unless I go to lunch or if it's a step down patient that's able to go off the unit, I never am fully able to give the authority of the patient over
Mm-hmm.
to to somebody else. I still retain accountability for that patient, so it's a little bit more difficult. But if a patient goes to interventional radiology, if they go to surgery, I guess that would be a form of handing over accountability
Yeah.
to somebody else for that patient. Delegating, uh, I'm able to delegate getting blood sugars on a patient to PCT.
Mm-hmm.
Can't really give them delegate drawing labs or um, recording intake output or vital signs or anything like that in the ICU. But when I was on the transplant unit, was able to delegate, hey,
Mm-hmm.
would you mind going and giving this patient a bath, or things of that nature.
Right.
Supervising as a floor nurse, maybe supervising if a ancillary service comes in to perform a test on a patient.
Mm-hmm.
So I'm not capable of doing an echocardiogram
Right.
on the patient, but I can supervise while that echo tech is in the room, making sure
Mm-hmm.
that all of my lines and all of the equipment that we may have in the room for that patient are managed appropriately.
Mm-hmm. Yeah, that's a great example. I can definitely see where, I see there's a pattern of assigning and supervising as a charge nurse that's going to be different because you have a different role and responsibility, right? But delegating is something that happens often. And that's probably going to be, from my perspective, one of out of the three that you're going to do the most often is somebody working on the floor, right? Because that's part of balancing the responsibilities and the workload of care. That's why we have unlicensed assistive personnel, whether they be PCTs or CNAs, people there who support the nursing role. So the key there is knowing how to delegate appropriately in those instances. So when we think about that knowing when to do it appropriately, it's not always as straightforward as we would like it to be. It can be a little bit complex. So in our course materials, we have the 5 rights of delegation. I guess if we had a certain number of rights that works good for medication administration, we can use some for delegation too. So the challenge, though, with these rights is going to be applying them, especially quickly in real time under the pressures that we have throughout the day. So first of all, let's walk through what each of these rights are. So, the first right is going to be right task. And so, with that, we ask, is this a task that's appropriate to delegate based on the client's needs and the predictability of the outcome? We also have the right circumstance. So, is the client stable enough and the situation appropriate for delegation, considering the potential risks? Big one is going to be the right person. And you talked about this a little bit too. Is the team member trained, competent, allowed by their role and licensure to be able to perform that task? I think a lot of times we think about licensure and their role, but it's just as important to consider if that person has the necessary training to be able to do whatever that task is that you want to delegate. And then also the right direction and communication. So, did the nurse give clear, specific instructions and explain what to do, how to do it, and when to report back? And finally, the right supervision and evaluation, because every time we delegate, remember, we retain responsibility for the outcome. So, or accountability for the outcome. So we have to have some measure of supervision and evaluation in that process. So is the nurse following up, providing oversight, and evaluating both the task and the patient outcome? So going through all that very book type information, can you walk us through a situation where you had to think through those 5 rights while making a delegation decision?
Yeah, so I will say that when I learned this in nursing school, the idea that I would look at, I don't know, blood sugar and think through these 5 rights, I was like, that I don't know if that's actually going to happen, but it actually does,
Right.
and you learn to do it very quickly, and it's you come into it with inherent knowledge,
Mm-hmm.
based off of whoever it is that you're working with. So, an instance for me, um, as a charge nurse, I have to respond to codes
Mm-hmm.
throughout the hospital, and they don't just happen at the most ideal times. So you can be in the cafeteria, you can be in the middle of cleaning a patient, you could be in the middle of a procedure. And
Mm-hmm.
so a specific instance for me happened maybe a few weeks ago. I was relieving a nurse for lunch so that they didn't have to stay in this room during this hour-long procedure. And a code goes off. So I've still got this task that needs to be completed. You still have to be in there for this procedure. And so immediately going through the 5 rights of delegation, the task, okay, it has to be a nurse that's
Mm-hmm.
in this room while this procedure is happening. And so immediately know that I need what type of person I can delegate this task to. It's going to be
Mm-hmm.
a nurse. Next one, the right circumstance, looking at the nurses who are in the area around this patient's room. Um, does one of them have a patient that's too acutely ill to leave, or is there
Yeah.
somebody around that can be in this room for the next 30, 45 minutes, however long it needs to be?
Mm-hmm.
Again, right person or right, I guess, right task and right person, I kind of went in together with, but
Sure. Yeah.
right person being a nurse in the situation, the right kind of licensure. Um, and then communicating with them that, hey, look, I have to go off the floor. I will be off the floor. The nurse is currently at lunch. This is what I need done. I need you
Mm-hmm.
to be in this room for the next 30, 45 minutes while this procedure is happening. and then going back and following up with them after I finish with whatever I'm doing in the code, following back up, supervising and evaluating whether or not things happened appropriately.
Yeah, that's a great example. And I think an aspect of that example that I don't want to, skip over is the fact that that is a high stress, urgent, you got to make quick decisions right there. And you did say, it's kind of once you practice it, so many of these things are inherent, right? You're not gonna necessarily stop and go through, okay, am I choosing the right task? And but you start to develop the skill of delegating just like you would any other skill, and have that knowledge, so you can make those quick decisions and make them safely, where you're gonna have the best outcome for the patient in the end, and know that the patient's left in safe hands. So, yeah, that's very good, and you explained many factors around how you make your decision in that moment, and so it can go from that type of situation where it's more of a, I think of it as like a high acuity thing, all the way down to you're a nurse on the unit and you delegate to a PCT to help feed a patient, right? That's still, you think about a task of feeding a patient. It's basic nursing care. It's something that somebody with no license can do. The you have an available PCT, so that you have the right person there to do that. And you're going to communicate to them, what if the patient has some type of food restrictions, right? Or they're on a full liquid diet, something of that nature. And so you got to make sure that that part is clear. And then you come back and follow up. How much did the patient eat? Did they tolerate everything well? Things of that nature. So, great examples. It can go from really something very simple all the way to that complex situation that you described, which is a wonderful example. So, let's talk a little bit back, and focus on the having the right person, because I think that's a big part of delegating that needs to be emphasized. So a lot of times we're clear about what needs to be done, but that's not enough. We also have to know who the right person is to do that. And when we evaluate who that right person is, we need to assess and verify the competence of that team member that we're delegating to. And also, as we've already touched on, and it may sound like a broken record, but it's so important, what is their scope of practice, right? And not just that, but have they had the appropriate training, and do they have the skills to do whatever it is safely? So, in your experience, who do you typically have available to delegate to on your unit?
Sure. So in my role as a charge nurse, I'm typically going to delegate to a nurse on the unit. Um, be that there's somebody that's busy in another room, but this patient needs their medications. I can tell a nurse, hey, go pass this person's medications for them. But when I'm working on the floor as a floor nurse, I'll typically more delegate to a PCT or an
Mm-hmm.
unlicensed UAP,
Yes.
unlicensed. Yes,
As
yeah.
assistive personnel,
There we go.
the textbook terminology.
Okay, thank you.
Yeah,
Yeah,
exactly. And I'm trying to think about, any other ancillary people that we might have available, but I think on most nursing units, one other team member that comes to mind that we might see more and more on a unit is going to be like an LVN, a licensed vocational nurse. I think we're seeing those used more, especially as many hospitals are moving to more of a team-based approach to nursing care rather than RNs doing total care, total patient care. So, yeah, so delegating to nurses, delegating to the PCTs. How do you assess their competence before deciding to assign or delegate a task to somebody?
so for nurses, I'll look at maybe years of experience,
Mm-hmm.
what different competencies they have as far as devices go, um, and how good they are in stressful situations. Is this somebody that's capable of handling two really acutely ill patients, or is this somebody that maybe is not quite there yet?
Mm-hmm.
For PCTs, I'll look at maybe their experience with ICU patients. We've had
Mm-hmm.
a period of a couple of months where we are getting a lot of float PCTs who aren't as familiar with vents and the different things that they may see in the ICU.
Mm-hmm.
Uh, so yeah, just looking at where they come from and what their skill level is and what their knowledge level is.
Yeah, that's a great example. And like you said, their years of experience, their confidence, their, and the new grads as our students are going to graduate and go into the healthcare environments, they'll feel themselves when they feel like they're ready for something to be assigned or delegated when they're not, and the discomfort that might come with that at times, which we'll talk about here in a little bit. So, what are kind of like the red flags or green flags that you're going to look for when you're delegating a task?
Um, Green flags mainly willingness to learn, and ability to handle rapidly evolving situations.
Mm-hmm.
Um, Somebody that wants to do it is, I mean, I guess that's maybe not a good green flag, but you can tell the difference between somebody that really wants to be there and really wants to be involved in the team and somebody that's not.
Right.
So I guess the red flags would be the absence of those things,
Mm-hmm.
absence of willingness, absence of ability to learn and evolve.
Mm-hmm. Yeah, definitely things to take into consideration. Um, and also, when we think about the right supervision and evaluation, sometimes we have team members who might not meet the standard, and we have to address that, right? And that can be kind of tough. It can feel kind of confrontational. So, how do you navigate those moments when the performance isn't quite where you need it to be? And maybe if you could think about that both from the standpoint of being a charge nurse, because that in itself is a supervisory role, so that constructive feedback might kind of feel like it's expected. But as a float nurse, or I'm sorry, not a float nurse, as a floor nurse, you delegating something to a PCT or an LVN. There's still some measure of that supervision and evaluation that's involved in this. So, how do you navigate those moments when performance isn't where it needs to be?
Yeah, so it can be tough. I think that you have to look at the situation and maybe try and evaluate why those standards aren't being met. What the reason behind it is. If it's lack of education, maybe just taking the person aside and providing the education about how to perform the task in the way that
Mm-hmm.
it should be done. I feel like that's normally a sufficient response in those situations. I need to evaluate whether or not I gave clear directions and communicated effectively about what I needed done.
Oh
Um,
yeah, that's good.
and so if I evaluate myself and realize, hey, maybe I wasn't very clear with this, looking to be more clear in the future. And then if it's somebody where a team member just really doesn't want to perform up to the standards, that's a whole different situation, and I don't feel like that's super common.
Mm-hmm.
Escalating it appropriately to whoever it needs to be escalated to,
Right.
um, and perhaps evaluating whether or not it's safe to continue delegating those things um, to that person.
Mm-hmm. Yeah, those are some great points. I really appreciate that you pointed out that personal reflection too, because that was one of the things we talked about in delegation is that we give the right communication. And if we haven't done that well, then we can't expect that somebody's going to follow through at the standard that we need them to. And also, escalating any issues to the right person because we don't want if there's issues with standards of care or follow through with delegation, um, it needs to be addressed because we don't want to always be delegating to one group of people because somebody else is not doing what they're supposed to be doing. So those are some great ways to look at that, and always an appropriate way to handle it from that supervision and delegation and evaluation perspective. So okay, so as we kind of talked about already, delegation, it doesn't always happen in calm, perfect conditions. It usually happens in the middle of chaos, especially when you get to a point where you have to start delegating things to people. And maybe for some of those, like myself, that I just feel like I should be doing everything, usually pushed to a point of delegation. So let's say you've got a situation here where you've got two new admissions that came in, you've got a patient that just got back from PACU that needs close monitoring. You have another patient that's high acuity, and now you're short a team member. So it's loud on the unit, it's busy, you've got decisions to make really fast. And this is where those five rights of delegation are really going to be tested. So, in that type of a situation, what does effective delegation look like to you? And how do you prioritize under pressure without compromising safety?
Yeah, so it's difficult. Nothing ever really goes wrong when you're overstaffed. It generally happens when you're understaffed or lose a team
Hmm.
member, things like that. I think it really comes with evaluating and knowing who you're working with on a given day and recognizing what that person is capable of handling.
Hmm.
Uh, because the most important thing is making sure that all of those patients receive the care that they deserve, right?
Right.
So would likely delegate the care of a less acute patient to a nurse's neighbor. So the patient that's coming in hot, maybe telling that person's neighbor, like, hey, I need you to look out for this other patient while this person is tied up in this room.
Hmm.
Um, and evaluate whether or not an assignment change needs to be made.
Hmm.
Uh, as far as delegating under pressure without compromising safety, I think that all of that ends and begins with knowing the staff and knowing
Hmm.
what they're capable of. Um, you know which nurse is going to be capable of providing the right type of care to 3 ICU patients, and you know which types of nurses are not going to be capable of doing that.
Hmm.
Uh, and so, just yeah, I think it all just boils back down to knowing who you're working with.
Right. Yeah, that's a good point. And I think about too, knowing what resources you have available, right? Because, um, you know, maybe you can call on a float pool or in a case where you might have somebody on call, there's you have to really be kind of proactive in your thinking and understanding that these situations may happen and knowing an idea of which direction you want to go. So, and a lot of times these things, they're unexpected. Like you might come onto the unit for the day thinking a certain line of events is going to happen, but it goes a totally different direction. So, um, I think also being calm under that pressure is going to be important too, because your team members are going to look to you for that, steadiness and calmness in those circumstances. So, okay. So when we look at supervising, we want to think about supervising from a standpoint that is not micromanaging, because that doesn't ever really help. So once we hand off a task, though, with delegation, we're not just done with that task. We're kind of just beginning that process because, as we've talked about, there's a big piece of follow up that comes with delegating anything and making sure that everything is completed correctly and safely. Because as the nurse, in those circumstances, you retain accountability for what that outcome is going to be. So this is where supervision starts to play and factor more into it. So whether you're the delegating nurse or you're the charge nurse of multiple staff members, supervision requires being present, even if it's indirect presence. So it involves giving clear upfront instructions. As you talked about, communication is key, checking in periodically on how the task is being done, evaluating both the outcome and the patient's status as well. But it also involves recognizing when things are not going as planned and identifying additional support, or resources as needed, or changes in the plan as you originally made it. So once you've delegated a task, how do you follow up in a way that supports your team while still holding everybody accountable to the work that they're doing?
Yeah, so I'll normally keep mental notes of the things that I've delegated and following back up with the person that I delegated a task to. It kind of depends on what the task is, but generally I'll start by asking, if they have everything that they need in order to continue on with their day. And then I'll follow up and make sure that the task has been completed. If it's something that I'm not able to just check in on
Mm-hmm.
the EMR or whatever. But that I feel like when you check in on their day and ask them, if they have everything they need, if there's anything that you can do for them, and then following up with, has the task been completed, shows them that, I'm here to support you. I'm here to give you the things that you need or support you in the best way that I can, but I also need to make sure that the things that I've asked you to do have been done.
Right.
Um, I think people respond to that generally pretty well,
Mm-hmm.
because they feel supported, and then they're also like, oh yeah, well, yeah, I did the thing that you asked me to do.
Yeah. Yeah. That's good. And the check in that support, I think, is worth the emphasis too, because it kind of gives, I don't know, everybody likes to know that you're there to help them and support them, to ask, do you need help with anything, or how's it going? Or, instead of just delegating and disappearing and then coming back and making sure it's done. Right. So I think that's an important aspect of that. Okay. So let's kind of shift gears a little bit and focus a little bit more on assigning. You talked a little bit about how you make assignments. Um, I think when it comes to a lot of the things we're talking about, there's just kind of this undertone of team trust that's really important, and open communication. Um, so we can, as nurses, we can be responsible for assigning in either a downward direction, like you're talking about as a charge nurse, you're supervisory, you're assigning to the nurses on your unit, or a lateral direction across the care team. And there's a few factors that we want to consider. One of them is going to be client factors. So that's going to be the patient's condition, the level of care required, any special considerations there. We also have healthcare team factors, which involve the knowledge and skills of your team members, how much supervision is needed, their licensure, even nurse to client ratios, and experience with similar types of patients to the one that might be assigned. And then we think about additional factors like when a nurse is assigned too many high acuity patients or asked to float to a unit outside of their area of expertise. That's where we can start to have some safety concerns and can walk a fine line of what's an appropriate assignment. So, even with thoughtful planning, there's times when some things just don't go right. Nurse might feel like they're stretched too thin, they're overwhelmed, they're unsure about the assignment they've been given. And that brings us to something that's really important to talk about, which is what do you do when somebody feels like their assignment is unsafe? It's a tough spot to be in, especially for new nurses or students who don't feel really confident in speaking up yet about their comfort level with what they've been assigned, or knowing if, should I just accept this and move on, right? So what do you do if a nurse or a team member tells you that they feel like their assignment is not safe?
Yeah, so my first question to them is why do you feel this is unsafe?
Mm-hmm.
Because obviously they've probably gotten report or they have more knowledge, more in-depth knowledge about what's going on than I do.
Right.
So I'll ask them why. If they feel like their assignment is unsafe, not ideal, or just busy.
Mm-hmm.
And so if it's just busy, probably not going to make an assignment change unless I can. But I can make sure that they understand that I'm there to support them, what other resources they might have that can
Mm-hmm.
help support them throughout that busy shift. If it's not ideal, again, I'm going to look at the nurse and see, okay, these people are both pretty sick, but are you capable of doing this? Are you in the best, are you probably the best person for this assignment?
Right.
Okay, that's one thing. If it's unsafe, then we have to make changes to the
Right.
assignment, make sure that we're not putting a nurse in a bad situation.
Mm-hmm. Yeah. Very good. So, have you ever had that happen to you? Either someone coming to you with concerns or you personally feeling like you had an assignment that felt unsafe or too much or overwhelming? And how did you handle it?
Yeah, so from both sides, from working on the floor, I did get floated to labor and delivery
Oh,
a couple of
yikes.
months ago. Yeah, yikes. Uh, Went to labor and delivery, and the patient that they gave us patients on mag drips, which as an ICU nurse, you're capable of handling. But the other side of that was that one of those had a Jada in,
Mm.
and I was like, I work in the ICU. I don't know who Jada is.
Yeah. I'm
Please,
sitting here
please,
wondering the same thing.
yeah, please tell me who she is. But I just know that that's not something that I'm confident in. And so the charge
Hmm.
nurse came over and she's like, okay, I'm going to take care of this aspect of this. I just need you to manage everything else. And
Right.
so speaking up when I knew that I was out of my depth. But as a charge nurse, I have had, a nurse come up to me before and say, look, I've got this one who's acutely decompensating, and then I've got this one that's jumping out of the bed, and I
Hmm.
can't provide care to both of them. And she was right. It was an unsafe assignment. So I ended up giving her second patient to somebody else. That way she could be with the patient that was acutely decompensating.
Right. That's good. And those are both appropriate situations. You talked about when somebody comes to you, it's important to kind of get more information of why they feel the way they do. I mean, sometimes it is a matter of I know it's a lot, but I mean, this is the assignment you have to have today, but we're here to support you, right? And we have team members delegate effectively. You're making your rounds to help make sure they have what they need. But then there's other times when it's truly unsafe, and it is more important that you say when you don't know how to do something, like take care of Jada, whoever she is, or and not to just not let ego get in the way, right? Where you don't feel like you want to speak up and say something because you don't want somebody to think you're less than or whatever you want, however you want to put that. So there's different circumstances why you might have to speak up, but the important thing is that you do. Um, and then work together with the team to make sure that you have the best outcome. So, how can new nurses, from your perspective, and we touched on this a little bit, but anything that you would add about student nurses or new nurses speaking up and advocating for themselves when they're in those moments?
Yeah, I think it all just ends and begins with communication. Knowing that nobody is giving you this assignment because they, are trying to do anything nefarious.
Mm-hmm.
And from the other side of it is like maybe they don't know what all is going on with this patient. Maybe there's something that's happened. And so all that to say, I guess, just it all begins and ends with communication, speaking
Right.
up, and knowing that you can express those concerns because nobody wants to put somebody else in a bad situation or a bad position.
Yeah, that's great. Okay, so let's go a little bit of a different direction with assignment and talk about assigning rooms to patients. So, one of the things that comes up in the content around delegating supervision and assigning is actually making the decision on what type of room we're going to assign a patient to. And I know there's not, I feel like in most hospital situations, we don't have rooms where you have two patients sharing a room together, but there may be some times when we do, and we need to know how to make those room assignments appropriately and safely. So when we do that, and we're looking at what's the next available bed I have to put a patient in, we're going to think about infection control. We're going to think about safety, privacy, and how a patient's behavior or condition might affect their roommate. So, when you're helping make room assignments, what factors do you take into consideration for rooming those patients?
Um, Big ones being infection prevention.
Mm-hmm.
We are a hospital that does transplants, and so I need to make sure that I don't give a nurse, whether or not the patient's in the same room or not. If I'm making an assignment for a nurse for two rooms or one, um, I don't want to give a nurse a transplant patient who's immune suppressed or a chemo patient who's immune suppressed
Right.
along with a patient that maybe has C. diff or
Mm-hmm.
some type of bug that's not easily treated, that can't be passed to somebody that's immune suppressed. And
Right.
so I think those are infection prevention is a big one, and then safety, of course, just as
Mm-hmm.
far as acuity level goes, is another big one.
Yeah, those are great examples. Um, a lot of times too, we think about, if you're talking a more of a, well, I guess ICU or a regular, like a medical surgical unit, or intermediate care, we think about the acuity of a patient also in proximity to like the nurse's station. We want to put those that are higher acuity closer to the nurse's station. Um, but I appreciate that you touched on the infection control, because that doesn't make it a huge difference too, even thinking about it from a staffing perspective of going from one room to another. So, now I don't know, do you have patients who share rooms in your hospital?
No, I don't know what it's. I don't even think in the ED they do that.
Mm-hmm.
Uh, but definitely not in our ICU.
Yeah.
I know that there was talk of it during COVID, but that never came to fruition, thankfully. So,
Yeah. Yeah. I honestly haven't, I worked in a level one trauma center when I started nursing, and they were and that was, just a few years ago, but they were on their way of phasing out their cohorted rooms, or, shared rooms, non-private rooms. When I started nursing, may have had them just for a few years, but really it's not, I think it's not the standard anymore, but still something we want to think about. How would we decide who needs a private room and who can be cohorted is what it's sometimes called, or matched up with a roommate safely. And some things that come to mind in making those type of room assignments are going to be things like age and diagnosis. So trying to match roommates based on a similar age and compatible conditions, right? So if they have the same diagnosis or something similar, then it's less, it's a little bit more appropriate rather than something drastically different. Definitely client safety. I think that's one of the most important factors. But if you have somebody who wanders, who's confused, or has mobility issues, they might need to be closer to the nurse's station. And that's something we want to think about. Um, Infection control, you can sometimes put two patients that have, obviously you're not going to want to put somebody with some type of infective disease in a room with somebody who doesn't have that, right? If you're really in a tight situation, you could put two patients that have the same infection in the same room together. But those are a few things we think about. Definitely something for the students listening, you want to make sure you give some attention to in your resources, even though in most of our experiences, we're probably not going to see it happen in practice. So, um, okay, so to give a little bit of a recap to assigning rooms, I want to go over a few things. I touched on age and diagnosis and thinking about that from a roommate perspective, client safety, somebody who wanders, who might be confused, has mobility issues. We want them closer to the nurse's station, like I mentioned a minute ago, and even consideration for where they're placed in proximity to the exits too. We don't exactly want to make it easier for them to escape. Comfort and privacy. So um, if you have somebody who's near the end of life, they need to be in a private environment that's good for them and their family, or their caregivers. Definitely would not be placing them in a room that's shared with somebody. And we touched on infection control. So private rooms are required for clients who have airborne precautions or those who need a protective environment. They're preferred for droplet and contact precautions. So, like I mentioned, you can have clients be cohorted if a private room is not available, only if they have the same active infection, the same microorganism, or no other infections. And they have to be kept at least 3 feet apart. So even if they become buddies while they're in that same room together, we still want to be mindful of that infection control. So, okay. Our last topic I think that would be good to touch on is the factor of emotional intelligence in our delegation, because that's something that comes to play in how we communicate with people, how we respond. So it's a little bit more than just the logistics, but also protecting the patients and setting up the team for success. So when we're thinking about teamwork, it's part of a bigger picture when we start to sprinkle in the delegation, the assignment, and the supervision. So even when we have really careful planning, we can run into challenges like burnout, frustration, or even simple miscommunication. Like you said, communication is one of the most important factors. So these emotional undercurrents can really impact how delegation plays out, where you delegate something to somebody who's burnout, frustrated, not happy, and they respond in an unfavorable way that does not help the team or the situation. So, have you ever had to navigate a situation where burnout or attitude or even miscommunication got in the way?
Yeah, definitely. So earlier, even in fact, earlier this week, had a nurse that floated to our unit from our neuro ICU. Um, they had been being, they had been being, that doesn't make sense. They had been floated a lot recently. There's construction on their unit, and so they're being floated to the ICU frequently, right? So
Mm-hmm.
that's already something that's going to upset a lot of people.
Mm-hmm.
And so our unit was completely full. We had holds waiting down in the ED, and so this neuro nurse had transferred out her patient, and she was the only open bed. And so I said, hey, like you're gonna get another patient. This patient's been waiting for 3 to 4 hours. We gotta turn this room over fairly quickly.
Mm-hmm.
She expressed that she felt like she was being taken advantage of, that she wanted to make sure that things were happening fairly. And she was that's putting a nice spin on the way that she said it. But so and I took a second. I'm like, okay, this is not somebody this is somebody that's lashing out. They're upset about the situation, but what factors go into this? I can respond with by meeting where she is, or I can respond by saying, explaining a little bit more, giving her insight into how I made the decision, how I reached the
Mm-hmm.
decision that I made. And so I did. So I talked to her and I was like, hey, this is what's going on. Let's go look at the assignment board. I promise you this is all being done. Nothing's being done nefariously. Uh,
Right.
and even though she didn't like the fact was, or that the end result was still that she was going to get this patient, she all the wind got taken out of her sails because she's like, okay, I'm not gonna have somebody that's gonna sit here and argue back with me. I can't
Right.
really argue with somebody that's being level-headed and
Yeah.
telling you just what's going on. So
Right.
I,
Right.
I think I think that that's normally the best way to handle those situations is try and think about why that person's responding the way that they are.
Yeah. Yeah. That's such a good point. And I think, when there's emotional responses, we don't always benefit by matching those emotions with the same emotion that person is delivering
Definitely.
because like you said, everybody's got something going on and we might not know always what it is, but giving the time to listen to their concerns, but then also help them to understand. That was a great example, and part of what makes you so good at what you do. So um, in circumstances like that, you talked about providing the rationale, giving the explanation, giving that person the opportunity to say um, their frustrations or what's on their mind. What are some of the things that you use or the qualities that you think are important to lead through that situation and still make sure that the team as a whole and the patients stay on track?
Yeah, and so I think it goes back to just not meeting the emotion that they're at, and trying to realize that there's other things going on,
Mm-hmm.
uh, why she was responding the way that she was. Making sure that the team is feeling supported, making sure that appropriate care is being given to the patients. She was frustrated with me, but she was taking excellent care of her patients.
Right.
And so, I mean, you can't really, she was taking excellent care of her patients. And so there's no real intervention there, other than
Right.
just letting her sound off a little bit,
Mm-hmm.
and making sure that from that point on, hey, I'm available to help you land this patient. Hey, I'm available to set up a situation where somebody can watch your patient so that you can go to
Mm-hmm.
lunch. And just, even though she was frustrated, the rest of the day, still just making sure that I checked in with her as frequently as I check in with everybody else, and not avoiding her because she may
Mm-hmm.
have been upset. Um, yeah, just making sure that still make sure that they feel supported, I guess.
Yeah. Yeah. That's great. A couple of things that kind of stood out to me about that is not taking it personally because it's not a personal attack on you. I mean, in most cases, it really shouldn't be. Sometimes we interpret it that way. And it's also an example of how we're responsible for our response to people, right? We're going to control that to some extent, even on her side of things. But, we have moments, right? And so by you not taking it personally, not letting it get in the way of your support for her continuing on throughout the day, that makes a big difference. And also at the end of the day, the patients were being taken care of well. And that's what's most important. We want a good, supportive, healthy environment to work in where our patients are taken care of well. The people who are in supervisory roles hear our concerns and respond to them in a caring way, even if the outcome's not exactly what we want. So great. Those are great examples. So I think they're good examples of what make delegation both an art and a science. It's a fine balance, and your experiences that you've shared help to kind of give it some reality. Make it more real world than just reading some definitions on a page. So I appreciate you sharing those experiences. So one of the things I promised the students that would do throughout this conversation is help them on their exams, right? So I want to help show how this is going to show up on the exams. And to do that, I've got about 3 questions that we can go through that are practice NCLEX questions. And I have been so cruel and I have not given those to you ahead of time. So it's going to be a surprise.
I'm not
So,
nervous at
yeah, right. Do you feel like you're back in school again here? Are you willing to do them with me?
Yes, yeah, yeah.
Awesome. Okay, let me share my screen here. Uh, let's see here. Share this and let's put this into PowerPoint mode. Okay. All right. So what I'm going to do is read the question and the answers in case we have somebody who's just listening and not watching on the screen. And then we can work through them together. I can give you an opportunity to kind of answer them. Consider thinking out loud. That would be great to kind of understand your thought process, but we'll dive into the first one. So which client with an endocrine problem is most appropriate for the charge nurse to delegate to the licensed practical nurse or LPN? Is it A, a client experiencing Addisonian crisis with a prescription for hydrocortisone IV, a client with Cushing syndrome who needs intermittent urinary catheterization, a client with diabetic ketoacidosis on insulin intravenous infusion, or D, a client with thyrotoxicosis and new onset atrial fibrillation?
Sure. So immediately, I'm not super familiar with what an LPN is capable,
Mm-hmm.
what tasks are being, or what tasks can be delegated to an LPN. But still, I think I can answer the question based off of what each question has or each answer has.
Sure.
So a client with new onset atrial fibrillation, that's an acute thing. It's new. It's something that's going to require I would think an RN.
Yes.
Um, a client with diabetic ketoacidosis on an intravenous IV infusion, insulin. Um, I'm assuming that that would still need to be an RN because it's a continuous thing that needs to be changed frequently,
Mm-hmm.
based off every hour what the blood sugar results are.
Mm-hmm.
A client experiencing Addisonian crisis with prescription for hydrocortisone IV. I feel like that could be the response, but a client with Cushing syndrome who needs intermittent urinary catheterization, I'm more leaning towards that one just because
Mm-hmm.
it's the only one that doesn't involve medication administration. And again,
Okay.
not familiar with what an LPN can do.
Okay. Awesome. And I appreciate that because you don't work with LPNs on your units very often. So that might be a little dusty back there in the brain. And because it's been a few years since school when it might have been fresh on the mind. So I appreciate that let us know that because it shows how you can still have your thought process through what you know is appropriate for a registered nurse to do and your aspects of what's appropriate to delegate. So the correct answer is B. You are right.
Yeah.
Yay.
And
Okay. We got one down correct. So let's talk a little bit through the rationale. You're on the right track. So we need to remember that when we're delegating a task, we as a registered nurse, we retain the legal responsibility for the client's total care. So when we delegate, it has to be done appropriately. So routine procedures like the urinary catheterization are well within the LPN scope of practice. The other clients who have more crisis type situations are going to require the registered nurse. So LPNs are trained in many nursing skills. Sometimes they can have let's say they're include but are not limited to nasotracheal suctioning, Foley catheter and nasogastric tube insertion, dressing change, subcutaneous intramuscular and oral medication administration. However, IV medication administration is typically reserved for the registered nurse. That's I want to point that out from a standpoint of the what they're trained for in school and licensed for. Now, there are certain things that LVNs can receive like on the job training for and demonstrate competency with following school, but we want to just go with the basic, no ifs, ands, or buts of what their training is as an LPN. Does that make sense? So in that case, the things that require IV administration are not going to be appropriate. So A and C. And then also unstable clients. We would not delegate an unstable client as a registered nurse to an LPN. So like the new onset AFib, that's, that's not a stable situation. It's new. It requires assessment, more focused monitoring. So awesome. So the objective here with this one, I want to point out is that the charge nurse should assign the most stable client to the LPN, and that the tasks, which are exclusive to registered nurses, include assessment of an unstable client and intravenous medication administration. So I think we got that down on this one. So great job. Another thing I'm going to point out on this, just from, how does what we're learning in leadership and management show up in an exam format, is this question here is all about delegation, but it does require some level of understanding of these other things that are taking place in here. Kind of how you talked about if we have somebody on insulin IV infusion, they're having frequent monitoring, frequent adjustments, frequent titrating. So having some understanding of what these are, you don't have to know the diseases in depth or the diagnoses in depth, but we're going to pull on previous knowledge and put them into like delegating situations here on exam type questions. So something to point out there. Okay, number 2. The charge registered nurse on a medical surgical unit is responsible for making assignments. Which assignment made by the RN is most appropriate? Is it A, a licensed practical nurse assigned to a client receiving blood transfusions? B, a student nurse assigned to a client who requires frequent intravenous pain medication? C, an LPN assigned to a client 2 days postoperative appendectomy scheduled to be discharged today? Or D, an RN assigned to a client 1 day postoperative repair of a compound fracture?
Okay, so based off of your definition or explanation of what an LPN can do, A, assigned to a client receiving blood transfusions, I wouldn't think that an LPN could do that task without further education or whatever the hospital allows them to do. A student nurse assigned to a client who requires frequent IV pain medication, that's a no-go. An LPN assigned to a client 2 days post-op appendectomy scheduled to be discharged today. They sound very stable and like that's something that they can, an easy thing to delegate out. Only thing that gives me pause is, does the RN need to do discharge teaching? But I'll maybe still. An RN assigned to a client 1 day postoperative repair of a compound fracture. They're still fresh from their operation. So I would go with C.
Okay. So let's see what the answer is. Close, but not quite. Okay. So let's talk through this one. And it's okay to not get it right. It gives us an opportunity to cover it. You were on the right track. So I thought you were going to go with D.
I thought I was too.
You were on the right track with the fact that C is the discharge part. I think we're going to need to lean on the RN to do that part. So, we have to assign our RNs need to have the, hold on. The RNs are assigned to the client who's the most unstable. The words were not going to come out of my mouth correctly. So, following the client's orthopedic surgery, they're going to have frequent neurovascular assessments. They're 1 day post-op, and compound fracture is pretty severe, right? So they might have neurovascular assessments, pain assessments, drains, wounds, respiratory assessment. So anything that's going to involve assessment is a registered nurse responsibility. And then it's going to also require good critical thinking skills, right, to develop, implement, and evaluate a plan for this patient. So starting with option 1, administering blood is not within the scope of an LPN. So you are correct on that. A student nurse cannot give medications independently, so that wouldn't be appropriate. Plus, if it's IV pain medications, they're probably controlled substances like, morphine and stuff, so that's not going to be okay. And then also on, let's see here, and number 3, or letter C, a postoperative client is going to require thorough education, evaluation prior to discharge. The level of client education is performed by a registered nurse. An LPN may reinforce prior teaching completed by the RN, but not provide initial teaching or evaluate learning outcomes. So it's just right on the edge. We wouldn't want to be giving that discharge teaching if it's the first time and it be coming from the LPN. So does that make
I,
sense there?
yeah, I got lost in the sauce. The most appropriate, like always reread the bold
Yes.
before you answer. Yeah.
Yeah, you know what? It gets the best of us. So don't worry about it. We still know that you're very sharp and we don't have to, it's just a
I'm
pesky question.
yeah, I'm considering turning in my license. Don't
No,
worry.
no, 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 no. Don't go that far. Okay. One more opportunity. I feel good about this one. Okay. All right. The nurse supervisor tells the psychiatric nurse to float to the telemetry unit because the unit is short staffed. The nurse is not familiar with this client population and is concerned about providing safe client care. What is the best action by the psychiatric nurse? So, telemetry, psychiatric, it's two big different things. So, A, accept the assignment and ask about what skills need to be performed. B, ask the nurse supervisor if a more experienced nurse can go instead. C, read the policy and procedure book for the unit before providing care. And D, refuse to go due to concerns about client safety. I think this one's kind of a challenging one. So we can work on it together. What do you think?
Yeah, I think it's I don't think refuse to go due to concerns about client safety, even though it's valid. I don't know that that's the correct answer.
Right.
Read the policy and procedure book for the unit before providing care. Maybe. Ask the nurse supervisor if a more experienced nurse can go instead. Maybe. Accept the assignment and ask about what skills need to be performed. I don't know that you should accept the assignment before you know what skills are necessary.
Mm-hmm.
So for me, it's between B and C.
Yeah, I do follow your train of thought. I don't like that you have to accept the assignment beforehand, but if I think about, well, that they have it in that order, like maybe it should, I kind of like it to say just ask about what skills need to be performed, right? If we're in the actual conversation. Um, let's see, asking the nurse supervisor about a more experienced nurse to go instead. I mean, I don't, there's a short staffing situation here. I don't know that that's even an option, right? And the policy and procedure book for the unit, I mean, it's going to dictate how care is provided, but not necessarily like what you're doing in that assignment. And okay, I love the example that you gave about going to L&D because you're an ICU nurse, right? And L&D is a whole nother world. They speak a totally different language. They do different things. They go to places that we don't talk about in the ICU. I mean, I remember when I was working in CV ICU and I had a postpartum patient, 1 day postpartum, who was transferred to our unit for a possible PE, pulmonary embolism. And they were giving me a report talking about the fundus and all this stuff. And I'm like, fund what? I mean, it's been a while since I was in school and I haven't massaged a fundus or whatever we're supposed to do with that since I was in school, right? We all lay the same foundation, but you go and specialize in your area of expertise. So, but back to your example, you still went to L&D. You just made it really clear on what you could and could not do. So
Okay.
that makes me go towards A, just because the psychiatric nurse could go to the telemetry unit, but needs to be real clear on what tasks they are well trained for and what they're not. I don't know. What do you think?
And maybe I'm taking the word assignment too literally of accepting the patient assignment, not
Right.
necessarily accepting the assignment to go to the telemetry unit.
Right. Right.
But that's valid. You have a really nice way of telling people they're wrong, by the way.
Well,
Well,
I've had a lot of practice in my years, I guess. Okay, so let's go with A. I think
yeah.
that's going to be the correct answer. So when we kind of dig into the rationale, and these are I kind of did you dirty. These weren't very easy questions. I'm sorry,
How did
but
that work?
no, they require I mean, some really good critical thinking, right? And I have these because this is the kind of stuff we're going to see on the exam. So you got to really know your principles of delegation. You have to really know about scope of practice. You got to know about, how to handle things appropriately when they come up. And it's not always, the safest answer in some of this. In this case, the safest answer isn't running away from the assignment. It's just taking the assignment in the safest way, if that makes sense.
Right.
So, okay, so let's go over through a few points I have here in my rationale. So, when the nurse is asked to go, the psychiatric nurse is asked to go to the other unit, they need to clarify the duties and skills that need to be performed, which you pointed out, we all agreed on from the start. There could be skills like checking vital signs, administering medications, that are done on both units. So just the fact that it's a telemetry unit doesn't mean you can't do some of those skills. So nurses need to be assigned to clients with an acuity level that most closely matches their experience and then provide safe and competent care as well. So once on the new unit, they could be given a brief orientation, clarified applicable skills, figure out where they need to have a little extra support. More specialized care can be performed by somebody who's qualified and experienced, who's already on the unit, just exactly in the scenario you provided as an example. So for option 2 or B, asking for somebody else to go would be considered a refusal. And the supervisor can consider options, but, it's not necessarily appropriate in this case. For the letter C, you're not going to have time to read the policy book on specialized care. So I think that's a really practical thing, but that's something we got to think about. The nurse cannot legally refuse a float assignment because it is considered a form of abandonment. And unless the nurse can provide deficient knowledge or prove deficient knowledge in performing assigned tasks, then we're looking at abandonment situation. So the objective here, when asked to care for clients in an unfamiliar setting, the nurse should clarify the duties that need to be performed and any limitation in skills or knowledge of specialized care. And the nurses cannot legally refuse to float unless deficient knowledge in performing assigned tasks can be proven. So there we go. So I'm sorry, that was a hard one.
No, 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 no. I'm reevaluating my life choices and all of the
Please don't. You're an excellent nurse, and those 3 questions do not dictate your ability to do your job phenomenally. So thank you for letting me be cruel. I owe you big time. So, okay, last question I always want to ask everybody. What is the best advice you've ever been given?
So I thought a lot about this. Normally, my go-to is always persistence and determination alone are omnipotent, just because the whole quote kind of leads into you can be as talented as you want, you can be as knowledgeable as you want, but if you're not persistent or determined to complete a task or achieve a goal, then you're not going to get anywhere. But in light of this whole conversation, the never attribute to malice that which is adequately explained by incompetence. And the word incompetence can be interchanged there with frustration, burnout, sadness, or anything. But never immediately attributing the worst possible way of interpreting something to somebody trying to be malicious or take advantage of you, but instead try and see the whole picture.
Oh, I love that. That's so good. And I can see so many ways that's applicable in life in general, but in in just the high stakes, high pressure environment that nurses walk into, whether it's patients, their family members, our colleagues, when we take that type of perspective, it can totally change the outcome for somebody's day, for a certain situation we find ourselves in. So that's wonderful piece of advice. Thank you for sharing that with us. So, okay, thank you for joining me today. Your real world perspective on delegation and supervision helped make all these definitions and principles and stuff a little bit more tangible, and I appreciate that very much. So, we covered the 5 rights of delegation. We talked about navigating conversations, supporting your team, and all of that in the context of some really great situations that you've experienced. So for those of you guys listening, whether you're juggling assignments, you're crossing off your days till graduation, which I know you're doing, I hope that this helped to make delegation feel a little less abstract and a little bit more practical. The moments that are going to really matter are those split-second decisions that you have, the follow-up, the way you advocate for your team members, for your patients, and even for yourself. So remember that delegation, it's not just about handing off a task to somebody, but it's about using good judgment, knowing your team, always keeping safety at the center and the priority in your patient care. You don't have to have all the answers, but you do have to stay curious, ask the right questions, and lean into your growth as a leader to be successful in this category. So we'll keep building on this throughout the course. When you're preparing for exams, keep this in mind. Leadership and delegation are not going to always show up in obvious ways, but if you will think critically through the scenarios you're given, prioritize, think about how you're supporting others in their roles, then that will help you be successful. So thanks for tuning in to Leadership Chats with Dr. Wise. Until next time, keep learning, keep leading, and stay curious.